ICD drain.
ICD, very good. What type of ICDs? How many types of ICDs you are seeing here?
Water seal chest drain.
Huh?
Water seal chest drain.
Water seal chest drain. That is what we call intercostal drainage system. But how many bottles you are seeing? We are displaying this one bottle, two bottle, three bottle. So there are three different systems. Okay, one bottle system, two bottle system, and three bottle. So this is a picture showing the intercostal drainage with 1, 2, and 3 bottle system. Okay. What are the indications for each and every? What is the indication for an ICD? When will you put in ICD?
Pneumothorax,
Hemothorax.
pleural effusions,
Pleural effusion.
hemothorax,
Hemothorax.
empyema.
So it can be said as whenever you want to drain air, blood, or fluid from the pleural space, you can put in an ICD. If you want to drain air, it is pneumothorax. If you want to drain blood, it is hemothorax. If you want to drain fluid, it is pleural effusion. Okay? So air, blood, or fluid, whenever you want to drain, you can put in an ICD when they are in large quantities. What should be the height of the water column in the bottle? Now you can see, you are seeing the water in these bottles. So the underwater seal, what should be the height of the water column?
100 centimeter of water.
100 centimeters of water.
Sorry,
100
100 centimeter.
centimeters
100 centimeters.
100 centimeters below the chest level. That is the length of
Yes,
the
sir.
tube.
Yes.
But I am asking about the water column inside the bottle under which the tube goes to drain. This level I am asking.
2 centimeters.
Depth 2 centimeter. 1 to 2 centimeter. Yes.
Minimum 2 centimeters. So that the tip will be submerged. What are the advantages of this two bottle system compared to the one bottle system, which was the older method? You are seeing the picture here. No? Can you, by looking at the picture, can you see what is it? Is it going
keeps
under
at
the
a
water?
constant level. Underwater seal at a constant level.
Loudly, I am not able to hear your answer properly.
It keeps the underwater seal at a constant level.
Very good. So here the separate fluid collection bottle is there. So you can find out how much of the actual fluid, whether the pleural fluid or blood is nicely collected, and you can measure that. And this water column will remain the same. Okay, so fixed underwater seal level will be there. That is the advantage of the two bottle system. What is the advantage of and no cross formation here? What are the advantages of three bottle system?
Simultaneous control, suction, and drainage is also possible.
Very good. Adjustable pressure suction is possible. Drainage of both fluid and air is possible. There is no reflex back of fluid. So fluid will not go back in drainage tube. Very good. So what is shown here?
Triangle of safety.
Triangle of safety.
Triangle of safety.
Triangle of safety.
Yes, which is called the safe triangle or triangle
Safe
of safety for insertion of ICD. Very good. What are the boundaries? It is written here. If you are able to read it, you can read it. Otherwise, can you say it from your memory? What is this red line? Lateral edge of pectoralis major. This yellow line, the lateral edge of latissimus dorsi. The blue line is the fifth intercostal space. So actually, the apex of the axilla should be like this. So that's why it will become a triangle. But here, just to mark it, they have made it as a black line. So actually it is the apex of the axle, base of the axilla. So these are all the boundaries. Lateral edge of the pectoralis major, lateral edge of the anterior edge of the lateral dorsal, intercostal space and base of the axilla. Now how to decide that it is safe to remove ICD for insertion? You are wanting to drain the air or blood or fluid. When will you decide that you can safely remove the ICD? What are all the points you have to check? This
Air
knowledge is
leak has
important.
to be stopped, sir. Air leak has to be stopped.
How do you know air leak has stopped or
Minimal
not?
drainage. Minimal drainage.
And then,
And breath sounds are equal.
very good.
And patient is breathing normally without signs of any distress.
Very good. Any objective or recordable evidence?
Chest X-ray shows
That is the first and
expanded.
foremost thing. Just
Yes, sir.
to confirm the lung is fully re-expanded. Then no bubbles should be seen in the water seal chamber. And the last 24-hour drainage is less than up to 150 ml. Okay? These are the criteria for safely removing the. What is shown here?
Epidural catheter.
Epidural catheter.
Combined spinal and epidural catheter.
Is there only an epidural catheter? What is this?
Combined spinal and
Spinal and
epidural.
epidural.
It is a combined spinal epidural kit which contains a combined spinal epidural set. So what are all the components in this? What you are seeing here in them. What is this?
Yellow or syringe, sir.
Loss of resistance syringe. Very good. And what about this?
Spinal needle.
What size? Saying this spinal needle is
27
not
gauge.
27 gauge.
27 gauge.
27 gauge.
Very good. What about this?
2E needle.
2E needle. 2E needle.
Graduated, not 2E needle. Then what is this? This is the injection port to the catheter. Yeah? This is a filter, bacterial filter. So loss of resistance syringe, 2P needle, 27 gauge spinal needle, epidural catheter, bacterial filter, and lower lobe adapter. Okay? These are all the components. Who introduced this technique? And how did we do that? First of all? Okay, this fellow called Cure Laru introduced it in 1979. So at that time, he did not have all these equipments. So what he did was, he placed the epidural catheter in one space, then one space below, he gave us single shot spinal using a 6 gauge spinal needle. So he first placed the epidural catheter, then gave the subarachnoid block one space below. That is how the first combined spinal epidural was given. Later on, what do you call this technique? So this is called two-segment or two-level combined spinal epidural because he used two spaces. But after the introduction of a long spinal needle, which goes into the tooth needle, what is the technique called? It's called needle through needle technique. Okay? It's called needle through needle. What are the advantages of combined spinal epidural? Why has this technique become more popular compared to isolated epidural or single shot?
Prevention of
Single
multiple
prick
puncture.
only.
Prevention of
Multiple puncture sites.
multiple punctures. Okay.
Immediate onset of action.
Immediate onset of block. Very good. Then can we prolong the anesthesia? If surgery gets
Yes,
Better
prolonged,
post-op pain relief.
you can prolong the intra-op also. because you are putting in an epidural catheter, can increase the duration of analgesia by topping up through that, or you can increase the height of the block also and do post-operative analgesia. So immediate
It is
onset of block
titratable.
due to subarachnoid drug placement, adjustment of height of block using epidural catheter, prolonged intra and post-op analgesia, less hemodynamic disturbance, because the subarachnoid grows, we reduce it drastically compared to the single shot. So the hemodynamic disturbance is also less. What are the complications that this technique can produce? Any complication of central neuraxial block?
Dural tap.
Dural tap is way of doing dural tap purposely here because it's a combined spinal epidural. So what is the problem of dural tap that can produce? Whenever you make a hole in the dura, what is the complication you can expect? What is PDPH?
Post-dural puncture.
Post-dural puncture headache. So failure of spinal or epidural or displacement or migration of epidural catheter, post-dural puncture headache syndrome, Nagaswamy syndrome, subdural hematoma if the patient has any coagulopathy, aseptic meningitis, epidural abscess, bacterial meningitis. So all the complications of pulmonary blockage we are there. What is the dose of this drug? All of you know this drug, what is it being used for? What is it used for?
Malignant
Malignant
hyperthermia.
Malignant
Sorry, yeah.
hyperthermia treatment. Very good. What is the dose of this drug? Is 2 to 3 milligram per kg IV bolus followed by 1 milligram per kg. What is the composition of this drug? What all the components are present in the drug? Okay. So it is a sterile lyophilized powder of drandrolene sodium, 20 milligram per vial. Okay. You can see here it is written 20 milligram. So each vial contains 20 milligram. It has mannitol, 3 grams or 3000 milligrams. Sodium hydroxide to get a pH of 9.5. 9.5, is it alkaline or acidic?
Alkaline, sir.
Severely alkaline. Extravasation can produce all that tissue necrosis. What is the purpose of mannitol in this?
Solubility.
It makes it water soluble. Nandrolone per se, it is not water soluble. So adding mannitol, it hydrophilic. So how much of sterile water to be added to each vial to dissolve this powder? 60 ml for each vial. Okay. What is the mode of action of this drug?
Ryodyne receptor.
It is a ryanodine, not ryodyne, ryanodine receptor antagonist. Receptor is called ryanodine receptor. It is present in the, where is it present?
Sarcoplasmic reticulum. Sarcoplasmic reticulum.
Very good. So it, what is the role of mannitol? To that control to make it water soluble.
அடுத்த நாள்லயே பண்ணாங்களா ஒரே நாள்ல பண்ணாங்களா ஒரு கழிவை?
How soon it should be used after the reconstitution? Within 6 hours. Okay. What are the indications for its use?
Malignant hypothermia.
Only malignant hypothermia. Other indications?
Rhabdomyolysis, can it be?
Muscle spasm condition, spastic.
It is neuroleptic malignant syndrome and thyrotoxic. Also used. What is rhinodex? What is its advantage? So it's a new formulation, contains 250 milligram of dantrolene. Here it is only 20 milligram in one vial. So for an adult, you have to give 3 milligram per kg, 70 kg man, you have to give 210 milligrams. That means you have to dissolve 10 vials roughly. And every vial you have to put 60 ml. So it takes a laborious process. So in order to avoid that, now they have 250 milligram vials, which requires only 5 ml of sterile water to reconstitute it. So this saves time and helps for faster administration. So this is the new Rhinodex sampling is available as a 250 milligram per vial bottle. This is CT scan of a patient brought to the second emergency with a history of RTA. What do you see here?
Extradural hemorrhage.
Extradural hematoma, fantastic, very good. Left parietal extradural hematoma with a midline shift also. You can see the ventricle getting compressed. So how does it differ from subarachnoid hemorrhage or a subdural hemorrhage? This is extradural. So what will be the shape if it is subdural?
Subdural will be crescent shaped.
Crescent shape. Yes. So this is biconvex or lentiform, and subdural will be crescent shape. What is lucid interval? In head injury, you must know this terminology.
In extradural hemorrhage, patient there is a span of interval when the patient regains consciousness after a span of loss of consciousness. So that is called as lucid interval.
Very good. So person loses consciousness momentarily and feels better for hours and again deteriorates later on. So that period where he is looking normal is called the lucid interval. So that is why we always admit patients with even mild head injuries to avoid that they can become bad later on. What is Cushing's triad? What three things are called as Cushing's triad?
Hypertension,
Tension,
irregular
bradycardia,
respiratory cycle, and bradykardiosis.
Raised ICP, systemic hypertension, and bradycardia. What is the treatment for this particular extradural trauma? But already midline shift has taken place. What should it be done?
decompressive craniotomy.
Decompression or surgical evacuation as soon as possible. What are the anesthetic challenges in this particular case? We have to give anesthesia for this patient. What are the concepts you have to take? What is the most important frequency? Is the ICP be raised in these cases?
Yes, sir.
So, further rise in ICP, third hypotension, hypoxemia, and raised intracranial.
should be
Breathing. What are the methods of monitoring intracranial pressure? This is one of the theory questions that you can get in your theory exam. Can be invasive monitoring like external ventricular drain, intraparenchymal pressure, sensor, subarachnoid bolt, or epidural sensor, or it can be non-invasive. We have transcranial Doppler, thick nerve diameter measurement, encephalography, Exactly, spectroscopy. Just transorbital droplet, tympanic membrane distance. All these things are known. What is being shown here?
MRI, sir.
RA. Do you see anything else here? What is this?
Anesthesia workstation.
Anesthesia workstation. Anesthesia machine is there. The patient is being given anesthesia for MRI. Okay? So anesthesia in MRI suit. What are the indications for giving anesthesia for a patient in MRI suit? Who are all the patients who require anesthesia? Even investigation like that.
Claustrophobic.
Claustrophobic, hypooperative adults.
Pediatric.
Most
Pediatric
pediatric
patients.
patients. Needed for children and cooperative or claustrophobic.
Non-cooperative adults.
What is MRI safe equipment? Which equipment you call as an MRI safe equipment? There are two terminologies. One is MRI safe, another is MRI compatible. When will you call an equipment as MRI safe? When will you call an equipment as MRI compatible? MRI safe is it have no safety issues. Taken into the suit, but their function is not guaranteed, and it may interfere with MRI operations also. So, only thing, it will not get attracted by the magnet, fly like the other ferromagnetic object, but it will not guarantee a normal function of the monitor or the equipment. Then that is called MRI safe. Whereas MRI compatible equipment is not only it will not be attracted by the ferromagnetic but does not interfere with the operation of MRI as well as the equipment. What is Tesla? All of you know that MRI machines are advertised 1.5 Tesla, 2 Tesla, 3 Tesla. What does the word Tesla mean?
The power of the machine.
The strength of the
Magnetic
magnetic field.
field.
Okay? Tesla is the measure of strength of the magnetic field. What is the other unit to measure the strength? It's called Gauss. G-A-U-S-S. The 10,000 Gauss is equal to 1 Tesla. What is 50 Gauss line in an MRI? We all gone into an MRI room and seen. This is the safety boundary indicating a magnetic field strength where ferromagnetic objects become subject to significant movement. It may accelerate into the scanner, potentially becoming dangerous projectiles. So, any ferromagnetic object should not cross this line and go near the scanner. And it will be attracted by the magnetic field and fly like a projectile object, like a bullet, and cause damage. Which breathing system is used in MRI and what is its length? Last class, when discussing about breathing systems, we talked about this.
Maples and D.
Brain circuit. Okay? Brain circuit is used in MRI. It has a length of 5.4 meters compared to the normal 1.8 which we use for regular. So, how our apparatus dead space is decreased in that point I told in the last class. Let me see whether you remember that or not. Even though we are increasing the length to 5.4 meters, it means almost 16, 17 feet. How is the apparatus dead space reduced? because the gases are delivered through the inner tube very close to the patient. Okay? So that is the point of delivery of fresh gas flow or the location of expiratory valve besides the apparatus space. That point again and again. What is seen in this X-ray?
Bat wing appearance, pulmonary edema.
Huh?
Pulmonary edema, sir. Bat wing.
Pulmonary edema. Possibly, but bilateral ground glass opacity suggested probably COVID-19. Again, there is a popular rumor that COVID is coming back. So less virulently. The reason may include this. What will be the clinical presentation of the patient with severe COVID? The COVID cases coming back, you must recall your experiences in COVID time.
Hypoxia.
Clinical presentation.
Hypoxia.
What will be the complaint of the patient?
Fever, loss of
Most
smell
important
and
thing
taste,
of dyspnea
breathing
and progressive
difficulty.
hypoxia. What is CORAD's classification? So it's a system of assessing pulmonary involvement in COVID-19 infection. This is the level of, it is described in 6 stages, CORAD 1 to 6. 1 means there is absolutely no fear of COVID infection, normal non-infectious. Okay. ECT finding. 4H2, there is a low suspicion. Abnormalities consistent with infection other than COVID-19. 4H3 means it is indeterminate. So the first 3 grades, if it is 4H1, 2, 3, is not likely to be COVID. Whereas if it is 4H4, 5, and 6, very high chances that it is definitely a COVID. Okay? So especially 4H6 is a confirmed evidence that it is a definite case of COVID-19. What is the mode of treatment for this? What is the causative organism for COVID? Viral or bacterial?
Virals.
Viral.
So what is the drug to be given? Antiviral. So antiviral drugs, antibiotics, steroids in severe cases, mainly for correction of hypoxemia and oxygen supplementation by nasal oxygen, non-retreating mask, BiPAP, CPAP, and finally intubation, mechanical ventilation. And then very refractory hypoxemia, sometimes we may require ECMO also. What is ECMO?
Extracorporeal membrane.
Extracorporeal main
Brain
oxygenation.
oxygen. What is happy hypoxia? Or which condition causes this? Happy hypoxia. This itself is a self-explanatory thing. Patient is hypoxic, but he will not be dyspneic. Okay? So, despite being hypoxic, patient is still not having dyspnea. That is called happy hypoxia. Also known as silent hypoxia, refers to a situation where person has hypoxemia without dyspnea. It occurs not only in COVID-19 but also in conditions called walking pneumonia, altitude sickness, and rebreathing. Other conditions which can result like this is that. What are the indications for use of this drug? Calcium gluconate.
Magnesium toxicity. Membrane stabilization in hyperkalemia.
Hyperkalemia and
Magnesium
Hypocalcemia.
toxicity.
magnesium overdose. Used in hypocalcemia, that's the magnesium overdose in hyperkalemia. How is calcium metabolism controlled in your body? Three things you have to say. What are the three things?
Bones,
Parathyroid,
kidney,
kidney, kidneys.
Parathyroid,
parathyroid.
calcitonin.
Parathyroid hormone, vitamin D, and calcitonin. What is corrected calcium level? Is the calcium patients with low albumin, calcium that we measure directly may not be normal. So corrected calcium is calculated by the measured calcium plus 0.8 4 minus serum albumin. Right? 4 minus serum albumin. That is called the corrected calcium. So it has to be done in all patients who have a low albumin level. This has to be done. What are the actions of calcium in the body?
Muscle contraction.
Which muscle contraction? Skeletal or smooth muscle?
For coagulation cascade.
Coagulation. So all peptide for hemostasis, vital for structural integrity of bone, needed for use of acetylcholine at neuromuscular junction, which was skeletal muscle contraction and cardiac muscle contraction, and which are neurotransmitter in CNS. What is the difference between calcium gluconate and calcium chloride? This is another common question in Raisa. There are two preparations marketed. One is calcium gluconate and another is calcium chloride. So what is the difference between the two? Calcium chloride has got higher calcium content, 3 times more than calcium gluconate. So it is administered at 1/3 of the volume of calcium gluconate, but because of the high calcium content, it is more irritating. Whereas calcium gluconate is less irritant to the DV. What does the EKG show here?
Osce is
Osce
Outside is D
This
point.
is
Polymorphic ventricular tachycardia. Like this one. What are the causes of this condition? What causes? So it can be because of coronary artery disease, resulting in cardiac ischemia or infarction, valvular heart disease, cardiomyopathy, electrolyte imbalance, or drug induced due to cocaine, detoxing, or cocaine. And what is the treatment of this condition? To see this abnormality in the patient.
Treat the underlying causes.
Treat the underlying cause. Okay. So coronary artery disease, what will you do? So first thing is you must see whether the patient is hemodynamically stable or not. In any arrhythmia, always find out whether the patient is hemodynamically stable or unstable. Okay. And if it is unstable, go for DC conversion. If the patient is stable, give IV beta blockers, amiodarone, lidocaine, or magnesium sulfate. And if coronary artery disease is there as a history or additional information, immediately go for emergency angio and the whole of the block. What is the difference between cardioversion and defibrillation? Now for the ventricular tachycardia, we do defibrillation or cardioversion.
Defibrillation.
Ventricular tachycardia, I told you here it's a DC cardioversion treatment. So only if it is ventricular fibrillation, we have to defibrillate. So what is the difference between the cardioversion and defibrillation?
Defibrillation is with in coordination with the R wave and
R wave, very good. So the current has to be passed during R wave. Whereas in defibrillation, there is no pattern. So there is no R wave or anything. So you can give it at any time. So any other difference? Right, so these are all the difference. The purpose for is to restore normal rhythm in cardioversion as a fibrillation or a CT. And here in the cardioversion, we do in a non-emergent situation. Defibrillation is usually a arrhythmia, like particular fibrillation or pulseless CT. And it is a cardioversion, we always give a synchronized shock on the R wave, whereas defibrillation is unsynchronized. And the patient condition is usually in the cardioversion done in conscious and stable patient. Stable in the sense it is otherwise okay, whereas defibrillation is usually patient who have trusted or in the verge of arresting consciousness will be there. And usually you need to give sedation or anesthesia for cardioversion, especially in arrhythmic fibrillation. Whereas for ventricular fibrillation, patient will be usually unresponsive, so no sedation will be required. And for cardioversion, timing is often a planned one, not very emergent all the time. Whereas defibrillation will be very emergent situation and that will be done as soon as possible. What are the places where paddles for defibrillation are placed? Is the position described as placement of defibrillatory paddles in the chest. Can be anterior apical placement or it can be anterior-posterior placement. So this is called the anterior apical. So one over the intraclavicular region on the right side, over the apical of the intercostal space on the apical region. This is called the anteroapical placement of the paddles, and it is called the anteroposterior. There is the apical region, the correspondingly infrascapular region on the back. So this is called the anteroposterior. 64 years old man brought to the accident emergency with severe chest pain. While being examined, he suffered a cardiac arrest. But immediate CPR reversed him. He has a return of spontaneous circulation within return of consciousness in 4 minutes. He is now breathing spontaneously with 6 liters of oxygen by mask. ABG is sent. This is the value. pH 7.21, PCO2 60.8, Pica 15.4, PO2 59.4, KSHS minus 9.7. What is your interpretation of the ABG? You all been taught about ABG or not?
respiratory acidosis.
What acidosis? Metabolic or respiratory or both?
Res-
Hypoxia, respiratory acidosis.
No metabolic acidosis. What is the bicarbonate level? Is it normal?
No, sir.
No, sir.
So there is a low bicarb, there is a high PCO2 and low pH
Base excess.
and CO2 low. So it is a metabolic acidosis with respiratory acidosis and hypoxia. So how do you explain this condition? Why this has happened? The explanation is patient had a cardiac arrest, so both circulation and respiration would have stopped. Okay. It impairs perfusion to the tissues, leading accumulation of products of anaerobic metabolism. This is the cause of metabolic acidosis. The absence of respiration for quite some time leads to CO2 accumulation, leading to respiratory. What is Winter's formula? How is it used or useful here? When do you use this formula, Winter's formula?
To calculate the base deficit.
Calculate the
Base deficit.
what deficit. It is used in cases of metabolic acidosis. Find out what should be the level of carbon dioxide, whether there is any compensation or not. Okay, for that only you use the Winter's formula. Okay, Winter's formula is a tool used to estimate the expected partial pressure of carbon dioxide in arterial blood gases in conditions of metabolic acidosis. Here we have low bicarb, so we have metabolic acidosis. So we must see whether the PCO2 normally compensates for that. So what is the compensation? What do we do if a person develops metabolic acidosis? Forget about this cardiac arrest and other episodes. Any normal person who develops pure metabolic acidosis, what will the body do to maintain the pH at normal level? Which system will help immediately?
Respiratory system.
Respiratory
system.
system. So patient will hyperventilate and wash out the carbon dioxide. So in all cases of metabolic acidosis, if body wants to bring back the pH to normal, it will eliminate the carbon dioxide more than it should be. So patient will have low carbon dioxide. That is the compensation that patient will achieve. Okay. So to find out that, we can use this Winter's formula. So it helps to assess the degree of respiratory compensation. And the formula is what should be the expected PCO2 is calculated by multiplying the bicarb value by 1.5. So here you have 15.4, that should be multiplied by 1.5. To this you can add 8 and the final value can be plus or minus 2 can be added to that. Okay. So in this case, this patient has 15.4 as bicarb. We are multiplying it 1.5 times, which will be 23.1. And if you add 8 to that, it should be 31.1. And if in case if you want to add another 2 also extra, maximum it can be 33. But here it is almost double, 60. So it indicates that patient also has a respiratory component. That is how you confirm that it is a multiple disorder, not only simple acidosis metabolic problem, it is a respiratory acidosis. So later on when we take class on acid-base balance, we will learn about that. So here I am showing you a picture.
Gate control pathway of pain.
Gate control theory of pain. Very good. So it's called gate control theory of pain. Who proposed this theory? It's by Melzack, Ronald Melzack and Patrick Vall. It is by what types of nerves are involved in this particular pathway concept? What are the types of nerve fibers names you know? How is nerve fibers classified?
Erlanger gases classification.
Based on the size, speed of conduction, they are divided into alpha, beta, so A, beta, C types. Gate control theory happens at the dorsal horn of the spinal cord. Specifically in the substantia gelatin of the layer, 2 types of nerve fibers are involved. It's called the large fast conducting A beta fibers, which carry non-painful sensation like touch and pressure. Small slow fibers There are A, delta, and C fibers which carry pain signal. Now, when large fibers are stimulated, that is A, beta fibers are stimulated, like rubbing or a painful area, they can inhibit the transmission of pain signals from the small fibers, effectively closing the gate. And when the small fibers are more strongly irritated or stimulated, they open the gate, allowing pain signals to pass through the brain. So this picture will tell you that ultimately the signal has to go to the brain, to the sensory cortex to appreciate the pain. So the first step is the C fibers which transmit the pain from the periphery, they are stimulated and they are projected into a neuron which transmits it to the brain. And there is a beta fiber, when that is stimulated, what it does is it will stimulate the inhibitory fibers, which will prevent the transmission from here to the brain. Whereas if the signal from the C fibers is much more stronger, they will overshoot this and still stimulate this projection or the projection neurons to transmit the pain. So that is the concept that you have to understand. What instruments work on this principle used for pain relief? There's an instrument called TENS, transcutaneous electrical nerve stimulation, which is used for superficial pains by pain specialists, and which areas of the brain have inhibiting capacity to block the pain sensation. Pain pathway and all you have to know well, because as physiologists, this will be a very common question in the exam. So periaqueductal gray matter and cerebral aqueduct are the locations from where pain will be blocked. Just ask this and we will do that. What category of local anesthetic agent is shown here? How are local anesthetic classified?
Amides and esters.
Amide linked and ester linked.
Esters.
Very good. So is this an ester linked or an amide linked drug?
Short acting amide.
Is it an amide or ester? Chloro. It is written chloro. It's an
Chlorproprin.
ester linked local anesthetic drug. It is metabolized by plasma cholinesterase. What are the two presentations? It is present as 1% used for spinal block and 80% used for other modes. What is the indication for its use and why? The preferred drug
Short
for
acting
late-night
drug.
surgical procedures because of its ultra-short duration of action. It has no preservative. You see the composition, there is no preservative. And why it is not having any preservative? Because the earlier preparations with preservative found to be neurotoxic. So they were banned, so they were used without preservative. Which is the first early drug used and who introduced it in clinical practice? History. Idea? The drug which is extracted from a leaf, which when chewed produce numbness in the oral cavity. Cocaine.
Cocaine.
The first drug which was introduced by a person called Carl Fuller. You know any idea about Carl Fuller? Was he an anesthetist?
Dentist.
He
Dental.
was an ophthalmologist. Dentist is a good but he was an ophthalmologist, Vienna ophthalmologist. He was working with Sigmund Freud, who was a psychiatrist. Freud was doing research on cocaine leaves about their addiction potential. So this fellow was chewing this cocaine leaves, and his saliva fell into the eye of a patient. So when he tried to touch the eye, patient did not react. So he found out that it has some local anesthetic property, and he presented it and did surgeries using this cocaine drops. That is how it came to it. Which LA drug can cause methemoglobin? And in which drug it is used today?
Relocaine.
Relocate, very good. Which drug it is present nowadays? Amlachrine, very good. Cocaine is an amide local anesthetic causing hypertension. It is used as a topical preparation in amlachrine along with equal volume of treatment. These are some other questions to figure out your reading habit. There are a lot more questions. I will just stop here because I do have across 3 hours. We'll carry over to the next class and see. Okay.
Sir, can I
Ah,
ask one thing?
please.
Last time you had asked about alpine anesthesia. Is it used in it is a mode of anesthesia used where hemodynamic parameters are fluctuating?
It is not a mode of anesthesia. It is the behavior of the patient with a fluctuating blood pressure. At one time it is 180 by 110, next minute it is 90 by 50. Again you give some drug to make it 140, 80. Like that, if there is wild fluctuations between higher and lower level, that is called alpine anesthesia. Similar to the Alps where you go skiing. From height to bottom you go, then you swing and then go high up again. So this is compared to that alpine skiing moment, and that is not a correct way to anesthetize a patient. Okay, whenever you anesthetize patient with hypertension, you should try to maintain at a steady level. If you are not able to do that, and if there are wild fluctuations, it is called alpine anesthesia. It is not a particular mode. It is the abnormal way that BP behaves.
Yes.
Okay.
Yes, sir. And the other answer, sir, I could not find because the bag, you asked for the name of the bag, which is connected to the type 3 and 4 breathing circuits, Mapelson C and D, most probably.
That is called KHUN, pun bag. Okay, KHUN, that bag with the opening in the middle instead of the tail is called KHUN, pun bag. KHUN, pun bag. I'm
Thank you,
very
sir.
happy that
Thank you.
you are trying to seek the answers for the questions, remembering and then trying to clarify. I appreciate your involvement and passion. Thank you.
Thank
I
you, sir.
feel all the students should have such a passion to go and verify and read more. Okay. Right. Congratulations for asking those questions. Shall we sign off?
Yes, sir.
Marty?
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir.